Joan. I'm a Canadian family physician who also works as a restorative medical educator, facilitator, and coach. I create spaces that rehumanize the work of healthcare. I'm creating this podcast to remind myself, as well as anyone else working in a helping profession, that when you are working and caring for your human patients, you are the other human in the room. Hey there, healthcare human. Today's podcast guest is a fellow co-founder of the Hippocratic Collective, a brand new podcasting network made by physicians for physicians. I am thrilled to announce that the other human in the room is joining the Hippocratic Collective alongside other physician creators who are inspired to use their voice to humanize healthcare. Physicians need to be heard, not just consulted. Together, we're here to change that. Visit hippocraticcollective.org to learn more. Hello there, healthcare humans. Thank you so much for coming back for another episode of The Other Human in the Room. I am super excited to be sitting down with a fellow healthcare human, fellow podcaster, and I'm really actually just quite excited to get to know you better, Mel, because though we have met a couple of times virtually, we are really just at the beginning of what I hope is like a long collaboration and relationship across the countries and borders and everything. So with that as a little teaser, would you like to introduce yourself to everyone?
Sure. Oh my God, intros are so hard.
Yeah, whatever you want to say.
Yeah, let me see. My name's Mel and I live in Massachusetts and I have a husband and two kids and we have a bunny named Daisy. My kids are 9 and 11. I am an ear, nose, and throat surgeon, or at least I was until the end of last year. So I also have another board certification in lifestyle medicine, so I'm double board certified. I'm also a professional certified coach, and I have 2 TEDx talks under my belt. One is called How to Save Lives with 2 Minutes of Listening, which you can find on YouTube. The other one is called Seeing Beyond the Red Swans, which will be available in spring of 2025. And it's essentially taking the framework that was developed by FBI hostage negotiator Chris Voss and has revolutionized hostage negotiations and applying that to medicine. It's been adopted in many other industries, including finance and business and human resources, and it has completely revolutionized those industries, but medicine has failed to adopt it. And so I'm trying to introduce that because it's incredible and amazing and essential and could really change how we diagnose and prescribe.
Are you comfortable talking about that at some point during our conversation?
Sure.
That is quite a teaser. I'm like,
yeah.
Obviously, I will also watch your TED Talk when it comes to people, but I'm like,
of course.
That is a teaser. So cool. So before we dive into the revolutionary concepts that you share with other people, like on your podcast and in your coaching, I'd love to hear a bit of the backstory. So like, how did you first decide that you wanted to go into medicine in the first place?
Okay. Way back, let's see. I grew up pretty poor, like in poverty, with a mentally ill single mother. And I was just really like precocious and intelligent. And so like school was kind of like my safe haven. And so I got really into school and friends. They were like my family. And that's where I got a lot of external validation, right? I was kind of ignored at home or treated horribly and abused. And so I wanted to be at school all the time where everyone told me I was amazing. And so that started my whole like addiction to external validation, basically. Got a lot of dopamine there. And then at the age of 13, I was like, oh, I'm going to be a doctor, even though nobody in my family was ever a doctor. I had never been to a doctor, honestly. I don't remember ever having a pediatrician. I was unvaccinated, not because my mother was anti-vax, but because she was neglectful. And so I had no exposure to like Western medicine, but I was like, that's what I'm doing. And so I decided I was going to do it, and that was it. And so I set my sights on that. And let's see, at the age of 16, everything fell apart and my little family disbanded. And then I went and lived with a friend and her family. And I was like, oh my God, this is totally different in terms of what life is all about. That totally different than what I knew. And so I was like, oh my gosh, this is way better. So I got exposure to like normal family life, not obviously perfect, but much more normal than mine was. And then I had to just figure it out. So I was very resilient. I had a lot of grit. Like I was like, okay, I don't have anywhere to live. Where am I going to go? Okay, live with my friend. All right, college. In between college, like freshman year and sophomore year, I was like, okay, I have no home base. Where do I go? Let me study abroad. And so I just had to like figure out where to go in between each year of college until I graduated, and then had my own apartment, blah, blah, blah. Went to medical school. I also had an injury at the age of 16 where I was snowboarding with some friends, and I had never snowboarded before, and I went right into a fence, hand first, and I had a dislocated fracture of my hand, and I got to watch my own surgery. And I was like, oh, I want to be a surgeon. So that's when I decided that's what I was going to do. I thought I was going to go into orthopedics. Then I kind of flipped and I was like, oh, I'm going to do pediatric cardiology. And then both of those, I was like, no way. I saw a movie in medical school called The Doctor. It's like from the 70s, where this ENT doctor is diagnosing this other surgeon with head and neck cancer. And he is one of those like egos in a white coat who's just like treats patients as diagnoses, not as people. And then he becomes a patient and it completely changes how he sees people. And just that one encounter, I was like, ooh, I want to do what she's doing. And so I kind of rotated through the ENT service and I was like, yeah, this is for me. So I got into ENT and then matched, went to Baylor College of Medicine. So I was in Wisconsin at first. That's where I'm from. And then went to Texas, did a fellowship in Boston, met my husband. Then I was in academic/perpetual employment position at the University of Florida. And I was like, get me the hell out of here. I can't stand all the bureaucracy and the lack of autonomy. So I was like, private practice is for me. I did that for a decade. And I was really successful there. I left an extremely successful practice. I was the top partner, top earner, really amazing reputation in the community, took really excellent care of people. But I decided I was all done with that last year, and we can go into the details of that. That's kind of how I got into coaching when I was like, this isn't working for me anymore. Many things weren't working.
I would love to hear more about that. But even before that, I'm curious to hear a bit of what what training was like for you. So as you're going through your medical training and like experiencing healthcare, did you like, I don't think we even used the word burnout before, not that long ago. So it wouldn't have been that, but like, how did you fare going through, medical school, residency, surgical training, notoriously quite grueling, quite dehumanizing, etc. Override your body to the extreme. What was that like for you to go through that period of your life?
Medical school was amazing. I loved it because it was like you have the future focus and you can just study and fill your brain all the time. And I was like devouring things. I see it in my son, my 11-year-old, like he's reading The Goldfinch. And like,
wow,
I read that when he
precocious,
was,
right?
Yes, we can't give him books fast enough. Like, I think there's probably some Venn diagram of like giftedness, like high intelligence / ADHD. I've never been diagnosed with ADHD, but I'm sure I have it. And then like autism spectrum. I don't have any diagnosis of autism, but I can see some components there. Like I'm a major introvert. But medical school was great. And then residency was really awful. It was like toxic and I didn't fit. Like I am not someone who subscribes to vertical hierarchy. I didn't get it. Like I was like, I'm a piece of shit because I'm like the intern. I didn't understand the whole, like I always talk about this on my podcast too, but if you think of showing up in service to the patient, that's always been the number one thing for me as a trainee and as an attending, the 12 years that I was in practice. Showing up in service to the patient, always the first thing. Then the second thing was always showing up in service to myself. And so like I didn't understand all of the nonsense that we had to do, like the things that were non-essentials, basically, that we would wake up at 4 a.m. to do these things that were just for, like the program. For example, like getting all of this data just to present it at a morning conference to Bobby R. Alford, who is the guy who started the program. He's amazing. He's like a giant in the field. He's an icon. But he would listen to all of the patients at the children's hospital, go through this list of like 20 or 30 kids and not have any input. It was just for him, just to like keep this tradition of showing up at 7. I was like, why are we getting up at 4 a.m. waking these kids up so we can give Dr. Bobby R. Alford information that he's just not going to do anything with? It's not going to change management. Like, there's really no reason to do this. It's not very kind to be like waking these kids up. So just like little things like that where I'm like, what the hell are we doing? Or even, you know, after doing hundreds and hundreds of tubes and tonsils, having to cover an attending in the OR because the attending did not want to do any of the paperwork and actually didn't want to operate. They had other things they were doing. So like the way the process was, the resident did all that work, right? When you have something else going on, like a patient really needs your attention, but they don't want you to spend the time taking care of the patient that actually needs you to kind of do some legwork for them. You have to put that off to the side so that you can do this other thing that you don't see the importance in. So little things like that where I was like, I got myself in trouble a lot.
I was curious. Is it like, was this an internal chafing? But it sounds like, no, it's also external chafing against the system.
Yeah.
So what did that look like? Because people are very afraid of getting in trouble. But here you are getting in trouble.
Yeah, I got in trouble a lot. I don't know. Somehow I graduated.
Yeah. I think that's actually really important to highlight. People are like terrified of literally ever saying anything for themselves because they think that they will kick you out immediately. But I think people have a pretty strong investment to keep people on the pipeline. Well, they like need you to be there.
Yeah. Well, that being said, a couple of co-residents got kicked out. One of them, I don't know if they got kicked out. One left. One of my co-interns left and was like, get me the hell out of here. I'm going to go do dermatology. Good for her. Then the person that came in after her, like, left and went and did anesthesiology. And I don't know all the details for why he left. I don't know how that happened, but I think there were some interpersonal issues or maybe like, I don't know. I don't want to speculate. But then one of the other residents in our program, who's a really good friend of mine, was completely pushed out and was expelled from the program. And then she went on to finish at another program and then became wildly successful, went on to become...
was fined.
Yeah. And so, she's now climbing the academic ladder at a different institution as an otolaryngologist and making changes based on her experiences. So good for her.
Good for her.
Yeah.
Wow.
But I think what saved me, and I could be wrong, you'd have to talk to the people who worked with me, but I think the thing that saved me was that I was so good at taking care of patients and I'm a really good surgeon. I'm recognizing that, like, I know just based on how I was treated, how I was given so much autonomy in the operating room and trusted so much in the operating room and then also you can't really compare yourself, but like even with imposter syndrome starting to creep in, you're like, am I good at this? I don't know. And I'm operating with one of my senior partners a couple of years ago and she's like, wow, that was like a master class. And I was like, okay, I am good at this.
Yeah.
So I think that's the reason. And I don't say that to be like bragging, but I'm pretty sure that's why they kept me in. They're like, she's actually really good and she's going to be a good doctor. So we'll tolerate her shenanigans.
They saw the other value, even though you were shit disturbing, etc.
It was problematic.
That's kind of awesome, though. You're slightly my hero now. That's so cool. Okay, so I mean, I have further curious questions, especially so. You explored a few different clinical environments and landed in one where you say you were hugely successful. It sounds like, well, did you continue to enjoy surgery? Like, so there's being successful, being skilled at it. I'm curious, basically, why you decided to leave it after all of that. Because, there's a certain point in the movie where you're sailing off into the sunset and you found your dream setting and you're super successful, but there's like a record scratch because you're like, and then I left it all last year. And so I'm really curious, like, how did that part unfold?
I think it starts with the arrival fallacy where you finish and you're just like, oh, this isn't that great. It's like the Olympian walking off the podium after a gold medal. Like, you lose that future focus. You lose striving, and we're a striving, serving species. And so I didn't have anything to strive for. So I substituted making money. I substituted getting approval from my patients and getting like really good reviews and really good outcomes. But it wasn't enough. It was still external. It wasn't internal. Yeah. And then I didn't recognize that I was like overworking and on the hedonic treadmill, as Arthur C. Brooks says. And then the pandemic hit and it all got taken away and I had to like sit alone in a room. And I was like, oh my God, this is awful. Like being alone with myself, right? So then the terrified little girl who was unworthy came out, and I had to kind of deal with her because I would always vacillate between like, I'm not good enough, imposter, I'm just this poor little girl who is abused and people are mean to and isn't worthy and just wants to hide in a hole and not go out into the world. And I'm not worth anything, like I'm worthless. And then I go over to like, I'm this badass surgeon. So like there's this big cognitive dissonance between like these two identities. So then I started having insomnia and panic attacks at work, which isn't great when you're trying to operate and like your hands are shaking incessantly. And then I was like, okay, I have to figure this out. So I am just so resourceful. I was like, I will fly to the United Kingdom and get some new like whatever medicine for insomnia, because I like didn't sleep for like 3 months straight. And I didn't know what to do. It was just I couldn't quiet my brain. Like there was something really, really wrong with me. And I mean, I've had anxiety my entire life, which is probably a component of the environment I grew up in. And like, you know, a lot of the adverse, whatever, like, what do they call it?
Adverse childhood experience.
I had a lot of those ACEs. Yeah, I looked through those. I was like, ooh, I have a lot of those. And so I had found help for that in medical school, and I was on an SSRI for a little while. Then I got off of it when I had my kids, and then I realized like, oh, I probably need to be on that. Like, my alarm bells are going off just because the body keeps the score or whatever.
Yeah.
Like my body doesn't recognize that I'm safe. It thinks I'm really unsafe. And so, you know, I got back on medicine for that. That wasn't sufficient. And then I found coaching. And then I was like, oh my God, like this is everything I've ever needed. Like what? I'm not my thoughts. I was like, what the hell? Those are just suggestions.
They're optional stories we're telling ourselves.
Our stories are wrong. Yeah.
I relate deeply, especially to that bit. Like when you're like, oh, yeah, that reality is filtered through the stories we tell or the way we perceive, particularly the way we've been taught and conditioned to perceive is often how I think of it. But you could shift that lens, shift that perception, and then have it like literally a different reality. So then how did that then impact your work as you discovered coaching and were discovering that like some of these thoughts were optional? What started shifting for you?
Yeah, it's like when you shift a ship or you like take little turns, like you eventually end up somewhere different months or years down the line. So it was just tiny little turns. Like I knew I was starting to become myself again when my sense of humor came back. And like that moment, like I hadn't laughed in like months. Thank God for my husband. He was like the most supportive, wonderful human being. And my kids weren't well. It's so fascinating when the maternal unit isn't well. Like my kids were not well. They're just like, stop scaring mama. Like I was terrified of everything. And they're always afraid of like scaring me. And I was like, oh my God. And I had to like take them aside when I was better. And I was like, listen, there's nothing you can do to scare me. I only scare myself. Like,
it's beautiful.
Right. Oh. And I was in the kitchen, like making dinner or something. And I banged some pans. And my husband was like, what's that banging down there? I was like, nothing banging, just my body or something. I made a joke. Like, and I was like, oh my God, I made a joke. It's like that Sex in the City where Carrie comes out of her like Mexicoma after, I don't know if you've ever seen the movie.
I'm not deep into that universe, but others tell the story because others.
Well, she's just like her marriage falls apart, or her fiance, like she goes to get married and her fiance has cold feet, and then she goes on her honeymoon with her girlfriends, and like she's like in bed and can't get out of bed, and then she comes out of it and she makes a joke. That's what it felt like.
Lovely. And so then, like you say, the ship keeps shifting. And so then at some point you decide to offer coaching to others.
Yeah. So when I jump into something, like I really devour it. So then once I was like, I couldn't get my hands on enough information. And so then I found Martha Beck and I was like, oh my gosh, like Martha Beck is like Queen. My spirit animal.
Yeah.
Like I want to be the Martha Beck of surgery. I read all her books and then I took her coach training course and it was amazing. The Wayfinder coaching method. I'm certified through that. I'm going to be starting master coach training. Hopefully I can say that. I don't know if I can announce it officially yet, but I'm starting that this year. And then I will, that's the highest certification you can get in coaching, which is really exciting. But last year was like my year of immense capacity. Like I created so much stuff last year. I continued to work as a surgeon. I started offering coaching, and my coaching practice just grew around me. I built an Instagram following. I pitched and delivered a TEDx talk last October and then another one in February. And I got to the gym 6 days a week, slept 8 hours a night, showed up for my family. So it was just like the year where I was like, let me show myself what I can do. Like, what am I capable of? And I was able to do it without burning out. So I learned so many lessons with that, and how we have capacity if we don't exhaust ourselves with our own drama, and we find joy in the effort, and we're doing it from an internally motivated place, not for the external validation.
And so what was that shift like for you? Did you find it hard, or do you continue to find it, like, do you still have the default of seeking external validation? Or do you know what I mean? Like, what is that process like to shift from external to internal? What has that process been like for you?
I don't. I just did like a reel about, I have all of my degrees are all in like a box in a closet.
I saw that on Instagram.
Which is awesome. Just reminds me, because I'm like, what do we get when we finish? We get like a piece of paper that we put behind glass and put on our wall. And like, what is that? That's not anything, you know? And not to say like people should do that. I'm not poo-pooing. Those are really big things. Like, you should be proud of yourself. It has shifted from like, I'm so proud of me, you know, I'm really proud of me. I'm so happy that I did all of these things and I achieved all of these things, but they have nothing to do with my self-worth. You know, like, I am worthy without them. You can take them all away and I will be fine. You burn all of my degrees, lose all of them. I'm not going to have a thought about it. They're there for my enjoyment, not for my suffering. And so I'm not going to let them cause me any suffering. So if I don't have external validation, I'm okay with it. If I get it, I'm like, yay, awesome, right? It's more like I'm loving the human experience without it. It just adds to it instead of it's everything. I live for it. Without it, I'm nothing.
Such a huge shift, such a essential shift. And I think a piece of it is still enjoying it when you get it.
Yeah. You have to, it's good.
It's good.
It's not bad. I'm not going to vilify it.
Because honestly, at first, when I started listening to like certain coaching podcasts and stuff, like the way that my like self-critical brain interpreted it is like, oh no, I'm external validation seeking. I'm going to criticize myself for it. So now if I feel good when someone pays me a compliment, that's bad because it means that I'm external validation seeking. Like I kind of flipped a helpful concept on its head to make it less helpful for me. So I love hearing like, it's not about external validation being bad. It's just that if you only live for it, that's pretty exhausting and sometimes impossible, in that now you're leaving your life's value in the hands of other people who like have other things going on. And so that's tricky. Okay. So with that, I know like it sort of spins off of that. We're talking about like ways to seek joy and discomfort, and also ways to like get rid of the excess drama. Like what I hear you saying is like, though, if someone looked maybe at your calendar or at your to-do list, you know, what you accomplished last year would be a long list, lots of things there, but you created space for it by eliminating the unhelpful thoughts or stories, or however you would say it. And one big, really challenging story that I know sometimes I still feel, certainly folks I talk to in healthcare feel, and I would imagine especially people in surgery would feel, is like the sense that you are responsible for your patient's outcomes. And in the kind of way where then that means that you feel like you have to overwork, you beat yourself up if you don't get the outcome you desired, like all the different ways it can show up. I'm curious for yourself, as well as like when you have surgeon coaching clients that come to you that are really struggling with that, what do you tell them? Like, how do you help folks to shift their perspective about our role in relationship to patient outcomes?
Yeah, the main, I think, point, the cornerstone of a concept to understand is that when we attach our self-worth to outcomes, it's not for the patient, it's for us. It's for our own ego. That's an ego desire. Okay, so we are not doing it so that the patient has a great outcome. We're doing it so that we look good in the eyes of who? The committee in our brain, our mentors from training, in the eyes of other people, and our reputation. Where it's not for the patient. We're not taking action for the patient, it's for us. Just like perfectionism is not for the patient, it is for us. Perfectionism is fear of shame. It's a form of shame, fear of being deemed unworthy of love and belonging. So when we don't take action for fear of it not being perfect, it's because we're afraid of being knocked off the perfect pedestal. So when you have the imperfect outcome or an unhappy patient, now you're not the perfect surgeon. So I have this concept of like dualism. That is how I reconcile that, where you have to have these two conflicting views, like these two realms in your brain that have to be always present at the same time. One is that you're showing up with the intention to create 100% perfect outcomes for every single patient. That's your intention. You show up to work with that intention. You show up to the OR with that intention, to the clinic with that intention. That is what you tell yourself that you're trying to do. The other part is that you know that you cannot do that. So you have to have both working at the same time. So there's this like perpetual cognitive dissonance so that you know that you can't do that because you're not an emotionless robot. You're actually a human being. You're going to err. You're fallible. You're going to make mistakes. Things are going to happen outside your control. You don't have all the control in the world. Like I tell my clients, like you can't control all the germs in the world. Your patient has like an abscess. Your incision the incision that you made gets infected. You didn't do that. You did cut into them saying like, I hope this gets infected. I'm trying to hurt you. So our brain, again, the stories that our brains tell us, our brain often goes to, I'm a hack. I hurt someone. Okay. Yeah. And so when you get those stories, when someone comes in with like an infection post-op that you had no ability to control, and then your brain goes there, we have to distance ourselves. And that is the ego's desire to be perfect because you told yourself a story, I will be okay as long as every patient has perfect outcomes. Then I will protect myself. You can't do surgery that way. You have to have the two like differing views. You have to have those two parts where you're like, I am dually intending this thing, knowing that I can't do it because I don't have the control. And so I have to figure out where my control is. And when I have a failure, I'm not going to blame and shame myself. I'm going to evaluate it and extract value from it. What happened? Was it a move I did wrong? Was it a move I did right, but I did it poorly? Did I take the wrong move? Or was it something completely outside of my control? First, getting clear on what happened that led to the adverse outcome. And then once you know the details of what happened, if it's a surgeon-specific issue, evaluating what did I do well? What didn't I do well? What would I do differently? And then extracting value and applying that to the next time you do that surgery so that you're evolving and growing. If we don't and we just blame and shame, we hide it and we put it somewhere deep inside ourselves and we don't look at it, and then we have experiential avoidance and we have anxiety, and next time we see a post-op patient come in, we're like, oh, please be okay. Please don't have a complication. And we have like a complete internal freak out. Our heart drops out of our chest with every post-op patient. That's not useful. That is not for patients. You're not creating a sustainable career if you're going to have emotional distress every time a patient comes in to see you post-op. So the way to do that is to manage your brain around it, to drop perfectionism, to stop attaching your self-worth to outcomes.
I love the way you talk about it. Like, I want to like frame it or like say it back to you and see if it resonates the way I said, like how I received it. Like, so you're showing up and you're pouring your all, everything you have that day, that moment in your life to that time, into contributing towards the ideal outcome. Like, you're showing up and your desire is for them to have a good outcome. Maybe that seems obvious, but like having that in your mind is sort of course, we're not saying like, yay, everyone died. Like, no, it's still, we're going to do everything we can to support this person's body through this process. Like in terms of surgery, like the process you're going to help support them through while you interfere with processes that are causing them harm, like removing tumors or whatever, right? And then, so that whole time, your desire is for them to have the best outcome. Your actions are in service of that desire. And you also have full awareness that that may not come to be. So you're not attached to that being the only outcome that means you're safe and okay as a person or that you're worthy. It's almost like detaching from the outcome while still desiring the outcome.
Yes.
Yeah.
I call it strategic detachment. So I have like,
cool.
so you, arrived right where I go. And like, there's 3 forms of attachment as a surgeon. You can be overly attached where you're the perfectionist. You're like, everybody has to have perfect outcomes, or I'm not good enough, or I'm an imposter, or I'm going to be found out. And so that's like the overly attached surgeon, which a lot of us are because we care, and that's a good thing.
Yeah.
That's okay. I was there. I know what it's like. And then you have the strategically detached surgeon who keeps dualism at the forefront and is able to extract value from mistakes and failures and poor outcomes. Sometimes failures are just information that something may not be working. Not always. Yes. Sometimes adverse outcomes happen even though we did everything perfectly correct. Sometimes patients die even though we would have done everything the same. Okay? So it doesn't mean that the failure, or if you want to call it a failure, an adverse outcome doesn't always mean that we can extract value, but we have to evaluate it to see if we can. Yeah. And we can't do that from a place of, I'm not good enough. Yeah. We don't have the wherewithal. And so then the third form of attachment is like the completely detached surgeon. And so that is that we think of the God complex, where a lot of these humans exist in training programs. They tend to be chairs and program directors.
They have to just be the role models.
Yes, everybody has worked with them if you're in surgery, and they will maintain that facade of an identity no matter what. They will change the story. They will sweep things under the carpet. They will blame. They will make it so that they can do no wrong. Okay, so there's that version. Or there's the detached surgeon who's depersonalizing because they are so burnt out that they just have no F's to give. Either way, it's not good for anybody.
We don't want to end up there.
You don't want to end up there.
That's not the goal. Yeah.
You don't want to be a narcissist. You don't want to be God complex. And you also don't want to be depersonalizing because you just can't handle. You don't have the capacity. You want to be in the middle. And a lot of times what happens is the overly attached will end up as the detached.
Of course, because they're like, that's almost like what burnout inevitably does. It's like, because I think what we perceive, because I relate to the overly attached phenotype, and I mean, we both are women, socialized as women. That's interesting. That's part of it. And so, like, this is the way I'm a caring person. If I detach, I'm going to become one of these uncaring people, because often we don't see this strategically detached middle way person. We're either seeing sort of the micromanager hover and then burn yourself out, but you're a hero for that. Or these like ones that you can see like are either just, you can see they're quite unwell, or you can see that they're like the villain in a movie. You're like, well, obviously I don't want to be those people. So this is the only option available to me. But what if it's not?
Yeah, there's a third. I mean, it's the black or white thinking.
Yes.
Which isn't useful. There's always a middle option.
Yeah.
And I don't want to vilify the God complex narcissists because they tend to be really, no, it's okay. Yeah. They tend to be really good surgeons,
That's interesting.
But so I don't know. I mean, I love the whole reframe of the drama triangle of the villain becomes a challenger. So if we see these people as challengers, I didn't know that I value not attaching my self-worth to patient outcomes, or I didn't value not being an ego in a white coat and thinking I can do no wrong until that was presented to me. And I was like, yeah, that's not who I am. And I'm not going to go there. So thank you for showing that to me, human who is that way.
Wow.
So now I know who I want to be.
That's actually a really beautiful way. Because, yes, I can, like, there's folks that I've either worked with in the past or colleagues or, people you come across, and they can be challenging to work with. But if nothing else, they can inform you about which path is not your path. And that actually is a huge gift.
Totally.
Which way you're supposed to be going.
All the villains do. I mean, if we all look back our lives, any moment where, like, I remember in 3rd grade having a friend named Shayna. I remember her name because, like, big emotions create big memories. And she was like a friend of me. And, you know, our friendship would be there, and then it would completely collapse. And then we would send each other notes like, hey, do you want to be a friend? Yes or no? Like, check one. Be friends again.
This is triggering for me. Not seriously, but yes, I relate.
And I would always check yes. And she would always check no because she was like a mean girl.
Shayna, are you okay? Probably
Who knows where she is now. But, and then I met a friend who's like, her name was Anna. We're still friends. She's like the most interesting human being. And she was not super popular at the time. So, Shayna was popular, right?
Sure.
And then I recognized, I was like, I reject the popular mean girl for the quote unquote unpopular authentic relationship with this other person. And in that moment, I was like, I value authentic relationships. Right? So it was like, thank you, Shayna, for challenging me and showing me that.
Oh, that's beautiful, actually. I love that.
Yeah. Everybody has those moments if we look back.
Yes. You define yourself sometimes with, we're like, wow, I finally found a person, or I found a situation that's saying yes to. But often we've had to have a bunch of nope moments before we find that.
Yeah.
Yeah, that's huge.
And that's probably why, I'm sure you've had those moments. I think that's how we become podcasters and we have authentic conversations. We're like, this is my jam. I love this. I don't have any time for inauthentic conversations.
Nope. Yes. This medium, I'm like, oh, thank goodness. I was just talking to myself driving to and from work, and then like trying to shoehorn like serious philosophical conversations into like small talk that people didn't want to have.
Same.
So.
In the
this
clinic.
Is better.
Let's get existential.
I know. You're like, I know we're trying to like decide a budget, but like, what are we doing here? And everyone's like, I don't want to exist on that plane.
My patients would go there. They'd get in the pool with me.
Oh, patients are like all there, but it's often colleagues. And it's
colleagues.
Their self-protection. You got to know your lanes, and everyone's like, their lanes are valid and they're doing their thing. I don't know what the red swan thing is about, so I don't know how to transition, but I'm very curious about it. So,
okay.
Can you tell me about it now?
Yeah. So the whole idea of swans, I'll just give everybody, I'll assume no prior knowledge.
Yes.
The term black swan was used in the 16th, 17th century in Europe to describe a never event, like something that would never happen. There was like a saying in Latin. So if we say it in Latin, then it's got to be like really true. Like people accepted that as fact, right? And then in 1697, a Dutch sailor spotted a black swan off the coast of Australia, and he was like, "Well, fuck!" Like, oh, sorry, can we swear?
You can definitely swear, yes.
He's like, "Holy shit! Like, there are black swans in the world."
Wow.
Here we are in Europe, saying all swans are white. That black swans don't exist. We call everything that isn't true, we call it black swan. Yet black swans have existed this entire time in Australia. Wow. So then the idea of the black swan shifted from an impossibility to a perceived impossibility that is later disproved. And that became what the term meant. And so Nassim Nicholas Taleb wrote a book called The Black Swan. I think it was published in 2007. And he talks about black swan events like the 2008 housing market crash and 9/11 and maybe even COVID-19 pandemic, you could say. So it's all these events that had we just asked the right questions and paid attention to the unknown unknowns, those are the black swans. We can't find them or see them unless we look for them. We don't know that they're there if we're not actively seeking them and asking the right questions. White swans are known knowns. We know they exist. We all agree. It's all the established knowledge. In medicine, it's everything we learned in medical school, residency. We revere, we laud the white swans. We walk in and we're like, patient, here are the white swans. Like, do what I tell you. This is what I learned. Like, we shove this down your throat. Why won't you take it? Like, that's kind of how we do medicine. It doesn't work. People are like, yeah, no, thank you. I'm not ready to receive any of that. You didn't even ask for my buy-in. And then red swans, I came up with that concept as if, white swans are the known knowns, black swans are the unknown unknowns, black swans are everything. By the way, we have to identify those. Those should be priority one. Red swans are the known unknowns, so they're all the scary things that we imagine could happen but aren't actually happening. And they create double blindness when we get caught up in them. So it's cover your ass medicine. Now you're blinding yourself to your white swans and your black swans. And you're not seeing clearly how to help the person. You're just it's basically taking action in service to yourself. And I talk about an incident with my son where I, in the ER, and I was like, you are taking action right now. You are recommending, she gave us an option. He was in there for abdominal pain to either be transferred to another facility or leave against medical advice. And I was like, hold on a second. I was like, you are not saying that in service to my son. You are doing that in service to yourself. He had like, in, of course, you know, the doctor's child comes in with abdominal pain for 3 hours. All of the tests are inconclusive and borderline, like his white count is like 10, and his ultrasound, you couldn't see his appendix, and his Alvarado score is like whatever it is, where it tells you it could be appendicitis, you don't know. And so they weren't willing. They also couldn't get a good testicular exam. They're like, is this torsion? They had no information. And then he farts and it goes away. And he's completely asymptomatic. But that was a black swan. Like the resolution of symptoms that they ignored, they were so focused on getting an answer.
Yes.
And we need objective data. And I was like, he is good now. I was like, he passed a ton of gas. And he was like, I'm hungry.
So that's why. So they didn't give you the option of just discharging him because he was fine. But he was. Oh my God.
Until I was like, hold on a second. I'm giving a TEDx talk about this exact thing.
I'm going to draw you some swans here.
I was like, you are making decisions in service to your swans, to your red swans. She's like, what the?
Oh my gosh.
Yeah. And then she, I love her. I actually wanted to give her a good review. I never did. And I really should have. She like sat there for a minute. She was like, and she was like, okay, I'll discharge him. like she like internalized it, and she did the right thing. And she let us go. I was like, you are not, I was like, what is the cost of an ambulance transfer of an asymptomatic child from this facility to another facility? I'm like, it's 8 p.m. I have a daughter at home. He hasn't eaten. He's hungry. Like, she has school tomorrow. I was like, think of all of the black swans of the inconveniences you're creating for my family. Or you're saying pay 20, 30, who knows, $1,000 for a visit. Like, I was like, that's not a choice. You're putting me between a rock and a hard place. This isn't how this should be.
Yeah. And there were other choices. Like, the black swan was that there, like, those were the other choices that we weren't open to have as a possibility.
Yeah. And so black swans are essentially getting to know your patient. Who are they? Who depends on them at home? What are their financial concerns? What is their goal of treatment? Is it a problem worth solving? Like, you can't know these things unless you get to know the person in front of you.
Yes. Oh my gosh. That is, and then that the red swans blind you to having basically any curiosity about even the white swans. And like, I so see that and relate to that, where like, when you are so in fear of lawsuit or so in fear of whatever, that you like forget like med school 101, that is like, that's real. And you're like, oh my gosh, I always whatever. But like, you've forgotten because you were so like, this person's mad at me. I have to make them not mad at me. I have to make them not mad. Whether it's because you're afraid of a lawsuit or like, for me, I'm just was deeply socialized to be afraid of anyone being mad at me, whoever it was. And so then survival brain makes you forget all of your past knowledge as well as creativity and innovation, which is essential for practicing medicine, because each new patient encounter actually does have unique, I love the idea of like black swan, like elements that you couldn't predict that you need the patient to help you see.
Yes. It's very, so cool. It's very sexy. Like, the FBI uses it. I mean, that's why when I brought this framework, I was like, surgeons will be into this, as opposed to get to know your patient, like the soft skills, the touchy-feely, like listen to them. Yeah. No, I'm like, no, I'm finding some black swans here. Like,
that's brilliant.
Right?
Yes. Because they're, you know, because like I would argue, and part of it is, so like I'm in family medicine. So I would argue that some of the things that are, I'm not arguing like against you, but I would posit that like, even in my training, some of what you're describing are some of my white swans, like in terms of like, it is sort of the standard you get tested on, social context, etc. But it makes, first of all, it makes sense that different profession, like pieces of our profession, are trained differently depending on what the value, like what the system values that person thinking about the most. But that also means then that we may be missing the black swans of what we're having people forget about that actually could serve them. For example, the context of the human person for professions where that's less like strongly done. But like literally no matter what, like there's always unknowns. There's always things that we have not discovered. Like in my world, a lot of it is, well, things that cause chronic pain. what's happening? It's still a big black box, like syndromes of different kinds. Like, I think that for myself and colleagues in my specialty, a lot of it is like shame that we haven't been able to figure out something that literally
Yes.
no one has figured out yet.
Yes. Well, if you think of like, it wasn't that long ago where doctors were like, oh, your humors are off. Let's bleed. Let's like bloodlet you. But the way
Yeah.
medicine is like, it's a forever changing field. We get so strongly convicted about the current evidence.
Yes.
And we're like, that is the truth, with a truth with a capital T. And it's like, it's all just, we have to hold it all loosely. It could all be thrown out. We can't attach to it, and we can't treat, I mean, the way that we train doctors is like either have the answer or be shamed. That's not helpful.
Not great.
We have to be like, I don't know. This is what I learned. It could be wrong. Yeah. I don't
Yes.
know. Maybe it's reflux, maybe a PPI, maybe from Odidine or whatever, but maybe in like 10 years, they're going to be like, what the hell were they thinking? That
Yes.
clearly was not helpful for patients. It caused all these other
Yes.
problems. Like maybe everything we're doing now is going to be thrown out. And a century from now, people are going to be like, what a bunch of idiots.
Yeah.
You know, maybe they'll be judging us. We don't know.
Probably.
So like,
In some way, I would assume, because we're judging the past. So that means we're going to be the past at some point.
yeah, we are the ones who are now bloodletting people for their humors. Like, we
Yes.
can't be so attached to those white swans as if they're the end all be all. They're just what we have. There's so much we don't know. So then you have a don't know mind. You're curious. You're fascinated. You're like, you offer something to a patient. You're like, this is what you have. Based on what I know, like, this is what I think is going on. This is what I would recommend. I could be wrong. What do you want to do? You know, it's very different than like, do this. Or
Very different.
if you're asking them to do something lifestyle based, like, hey, do you want to talk about weight loss? Are you interested? And they're like, no, absolutely not. No problem. We won't.
Take it off the menu.
Yeah.
Not interested.
Yeah. I'm here for you. I'm here to serve you. So if you aren't ready, I'm not even going to waste my time.
Yeah, that's such a huge shift. I don't know if you've noticed, but for me, when I figured out I didn't have to, first of all, only give the white swan things I've been told, you know, and also not feel like a defensive or offended if they rejected them, like they're rejecting me, and then
Right.
make up stories of like those uneducated patients, etc., like all that kind of stuff that we can do.
Yep.
That was very not relaxing. And now that I get to say, you know, this is what I know, like basically, like I talk to my patients, sounds like very similar how you were talking to yours, like, let's see what happens next. But like this, I have this knowledge, you have input, let's like go on this journey together. Way less stressful, way more, not even just like less stressful, but like actually enjoyable. It's fun.
Enjoyable. Yes. Yeah. And then if they're like, well, what if they're very anxious? They're like, well, what if this? Well, what if that? Like, why is this happening? And you're like, you know what? I don't know, honestly.
Yeah. Huge.
Right? You're like, I don't know.
Yes.
And that's okay. And you're like, but let's focus on what's your goal? You know, like redirect them. I know you have all these anxieties. Let's get you where you want to go. Here's how I would recommend you go there. It's up to you if you want to walk this path that I have laid out. How can I support you?
How can I support you? And by the way, was it through your coach training that you came here? Because I feel, though I had some skills before, when I went through coach training and coaching, that was a big shift in mindset of how then I was like, oh, this is how we should be trained to talk to patients, like completely.
Doctors are coaches.
I think when we are, because we're least harmful and most helpful when we are coaches versus the other stuff that they train us to be, which is like
Correct.
yell at people.
Yeah. And be judgy. And like, there's a lot of dropping in coaching. Like, you drop your judgment, you drop your agenda, you drop your expectations, you drop everything in your brain. You go in there, and like the way I teach my clients to be clinicians is you go in with a don't know mind, you check all that at the door, your ego, and you just absorb their story, you like stand in their shoes as if you were the protagonist. And that's how you really, if you can envision when they're giving you their history, like you're them, that's how you really uncover those black swans, because it's like you're living their story. You want to hang on their every word instead of like getting annoyed that they're not giving it to you in the correct form for your how you want it to be. You want to live it, like, and then you remember them, and then you can step back and grab those white swans that you learned from training and incorporate it, like putting together a puzzle, and then that you'll arrive at the diagnosis so much quicker. And so that's why I say, like, this is how you efficiently diagnose. We will help people so much faster. I mean,
Yes.
that's why I was so efficient last year. My appointments were like 15 minutes, but I got to the diagnosis so quickly. And then I just had all this extra time to kind of like connect with people and then work on my coaching practice and build my social media. And like, because I wasn't spending all this time like in the weeds of the red swans or trying to force white swans down people's throats. And like, all of that is just unessential. It's non-essential.
Yes. I'm speaking more to the red swans. So like, are the common red swans, well, like fear of patient complaint, fear of lawsuit, fear, like what would you describe it? Any other
Anything
big
fear.
ones?
Yeah.
Oh, okay. All the fears.
Fear of making a mistake, fear of being wrong,
Right.
fear of missing something, fear of a lawsuit, fear of a board investigation, fear of a complaint, fear of a bad Google review.
Yeah.
All of that is self-focus.
Yeah.
It's not in service to the patient. You're not trying to help the patient.
Right. So then is the process that you sort of similar to what we said before when we were talking about like fear of bad patient outcomes or undesired patient outcomes. So like the process of letting go of them is like letting go of ego. So refocusing on why you're there and your internal motivation, or like expand more on how then we shift away from red swan thinking.
Well, they're important. Like red swans are complications. When we counsel patients, consent a patient, I'm basically handing them a whole bunch of red swans and being like, this could happen, like it's not happening now.
Yeah.
I don't expect it to happen. But you have to still use them. Like they're important. They're things that have happened in the past that inform what could happen in the future.
Yeah.
But we can't it's like buying into a story like I'm not good enough. Right? We have to separate ourselves and distance ourselves and categorize. So we're like, okay, black swans are the most important. Where are my black swans? Okay, I've gotten them. And then you're like, let me incorporate my white swans. And then there's my red swans. And they're it wants me to order this scan, but I'm not going to because I know it's not for the patient. It's for me because I'm scared. So you have to kind of like, we have a human brain. It's going to go there. You just have to distance yourself and watch it.
Yeah. And even like you can give it, you'll be like, okay, so you're thinking it could be this worst case scenario. Let's think about that for a second. Why do I or do I not think that that's really what's happening here? And maybe it could be a clue. And you're like, oh, I forgot to ask them this question. Like it might give you some information. But then if it's like, no, I actually think we've ruled that out to my satisfaction, not to certainty, because that doesn't exist, but to my satisfaction. I feel good about if it were to randomly happen, I feel good about what I offered. Like I could see, so it's still like a helpful process in the decision-making, but it can't be like the leader of the decision-making.
Yeah. We have to engage with that.
Yeah.
Yeah. It's like engaging with all these different parts. And then we're like the judge. Like the red swan is just like one, like the prosecution or whatever.
Right.
Like we have to just take all the stories and
thank you for your input.
Yes.
Yeah. That's great.
Just like the part of our brain that's like, you're not good enough. You're a bad surgeon. You're a hack. You're an imposter.
You're like, I hear you. Heard you a million times.
Yeah. I mean, our brains are so weird. We're just like, oh, this coffee is so good. You're not good enough. Like,
it's so true.
You're like, what?
Like, excuse me. I did not invite you to this party. Why are you here?
Yeah. So we have to have a little bit of distance. Same thing happens when we're coming up with plans for patients. It's like they have cancer and you're like, no, they don't. We don't have to get another scan or do another thing, or this kid has appendicitis or has testicular torsion. I'm like, you can't fart away either of those pathologies.
A new diagnostic clue has come up, which is that something new happened and we can incorporate that in. Yeah. That is a great story, by the way. I love that story. Oh my gosh, we're already at the end of our time and I'm so sad. I look forward to multiple future conversations with you, Mel, because I feel there's a lot that we have in common and I am so excited to watch your TED Talk. It sounds like it's going to be awesome and so helpful. Just like I think we need so many like metaphors, analogies, new language. That's not actually new, but new for medicine to outcompete the old ones. Because like those are so ingrained in us that we think it's we think those white swans, which are terrible for us, or actually red, I guess. But like, we think those are the only ways to think about medicine. And so I love always hearing new ones. And thank you for that one. That one was like delicious to hear, actually. It was so good.
Yeah, we need language. Otherwise, we don't understand it. We're just like, I don't know why this isn't working, but this sucks. I don't like this.
Yeah. It must be me.
Must be me. There's something wrong with me.
Yeah. Or even like, it must be this is like, this is the system, which that's true as well. But like, and that means I just have to leave. But like, what if there's a step in the middle where you can adjust your thinking and then evaluate if you want to stay or not? Like for example, yourself, you chose to leave, but like you did it on your terms and not thinking it was simply either you or the system, like there was nothing else that could change.
Right. Yeah. I mean, it's the black and white thinking, like staying is safe suffering, leaving is risky suffering. You kind of flip that narrative where you're, I mean, I always say diversifying the self is like so important, because if you just are a surgeon or a physician, it's like having a house with one room.
Yeah.
So what happens if the room burns down? Then what? So I showed myself that my value comes from my brain, and I can apply my brain in any industry and be successful. And then I was like, all right, I've closed this chapter. I'm all done here. I'm going to go do this other thing. I'm afraid, but I'm still going to do it.
Yeah. Congratulations. That's like, what a beautiful way to decide. Yeah. Like you say, to close one chapter and finish well at something, and then move on to something new and exciting instead. How cool is that?
Yeah. Not escaping anything. Just
right.
Evolving and growing.
Yeah. Because why do we have to do just one thing for our entire lives, actually?
Why?
No, we do not. That's a fake story too. Okay. So as we draw to a close, first, where can people find you on the internet?
Yes. melthackercoaching.com is my website. Instagram at _surgeon_coach. My podcast, Surgeons with Purpose. I think I'm on LinkedIn too, Mel Thacker, MD. I don't go there a lot, but I have a thing. I try to just do Instagram. That's my main social. Yeah. And then the podcast and my website probably are the best places.
Awesome. And the last question that I always ask is like, so folks who listen to this podcast, the majority are in healthcare, and they're recognizing that there's something about working in healthcare that is stopping them from feeling as human. Like they have a desire to feel more authentically themselves, more human, to enjoy their lives and enjoy their work and be comfortable being human, even in the healthcare workspace, often maybe feeling some amount of burnout or having experienced it recently. And so what words of encouragement or advice would you like to offer to them?
Be authentic. Like we pretend so much in this field. We need to inject some authenticity, just fearlessly and unapologetically. And I think patients would love it and lean into it. We think like, we can't be human. We can't say like, oh, I'm so sorry if I'm a little tired. It's because I'm post-call. If I'm not on top of my game, like, we'll get you where you need to go. Just make another appointment, like pre-framing visits with like honest things and having honest conversations with patients. They don't want fake emotionless robots. They want like actual human beings that they can connect with. Connecting and authenticity, I think, are like the two things. And however you can get there, if you're obviously take some time, if you're just like really depersonalizing, you don't want to be like, I'm depersonalizing and I don't really give a shit about you.
I am lordly depressed now, actually.
Yeah, get yourself taken care of first.
Yeah.
And then be a real human.
Yeah. Well, obviously I'm going to love that advice. Thank you so much. Awesome. Well, so for all listening, I hope you enjoyed that conversation as much as I did. I felt like so invigorated by it. And I'm going to be thinking about black swans and red swans. I just love that, and like applying that to my thinking and see what it shifts for me. So thank you so much. And for all listening, I invite you to do the same, and we'll talk to you next week. Bye. I would love to take this work deeper with you. Visit joanchanmd.com today and discover my growing menu of options for restorative medical education to suit your learning needs. I offer one-on-one coaching, customized workshops, and self-study courses that allow you to connect not only with my work on a deeper level, but also with other healthcare humans just like you. So if you want to start humanizing your work in healthcare to a deeper level and do it in community with others, please visit joanchanmd.com and find those options and what fits you and your life today.